Okay, hello everyone. My name is Jason Arora. I work for this organization here called ICHOM. I'm going to ask this question at the start. Who has heard of ICHOM in the room? Other than those who've already spoken to me before this event. Okay, so it's a good thing I'm here from that perspective as well. So the International Consortium for Health Outcomes Measurement is the organization that I work for, and our focus is very much on trying to stimulate and catalyze outcomes and value in the healthcare industry internationally. Now, my personal story is I started off as a physician in the UK, actually, which is often used as a gold standard healthcare system internationally that others aspire to. And whilst I was practicing, I remember seeing these problems on the front line that made me feel very much like a firefighter. The problems that I saw, there was no focus on data, very little focus on outcomes. There was a very small role for the patient in managing and in actually designing and trying to manage their own care. And in a way, I felt like the blunt end of a sword. And my goal was then to try and understand the system perspective, to say, what can we change at a higher level to give the physicians on the front line better tools to manage the care of patients. So this focus on outcomes and on patient-centered care is really the background that I come from. And it's fair to say that the challenges that healthcare systems face around the world, everyone faces the same challenges, but everyone's in a different part of the spectrum. And so I'm going to go over quite a few things today that we see are the challenges, both internationally and here in, well, not just in Latin America, but specifically in Brazil as well. So the agenda that I had here was just to provide an introduction to this concept called VBHC, or what we call value-based healthcare. How many of you know a little bit about this already? Okay, so it's good I put that at the start of my presentation as well. I'll then speak a little bit about ICHOM's role, what we do as an organization, not to provide a pitch for ICHOM, but more to explain what we see the journey to achieving this concept of VBHC is going to be like. What is that journey going to look like? And therefore, what should every healthcare system be thinking about? I'll then explain a little bit about our work in the life sciences space, and specifically what we're doing at MEdtronic. And then in the second half of this talk, I understand there are two halves to this, I'll give you some examples of the successful application of this concept internationally. So let's just start with one of the problems from a system perspective, and that's where health outcomes are concerned. So variation in health outcomes is an international problem. There isn't a healthcare system in the world that doesn't face this. You start in the US, for example, a 2 times difference or variation in the mortality rate from heart attack after 30 days. So as a patient, if you see that, you're thinking, well, there's a twofold difference in my outcome, but I don't know what's going to determine that. You go to the UK, which is where I used to practice, a 4 times variation in bypass surgery mortality in UK hospitals, a nationalized healthcare system with a population that is the same as this city, I understand. You go to the US again, 5x variation, major obstetrical complications. And this is obviously a very common thing that is done. So that's going to affect a lot of the population. You then go to the Netherlands, 9 times variation, looking at radical prostatectomies. Germany, hip surgery, 18 times variation. Sweden, colon cancer, cataract surgery, 20 to 36 times variation. So where trying to achieve good outcomes for your patients is concerned, whether you are a provider, you're a clinician, you're a payer, you work for the government, medical society, whatever, that's a problem. But this only just starts to scratch at the surface, because for the outcomes that matter most to patients, the improvement in their symptoms, their functioning, their well-being, there's a lot behind this that I'll get into in a moment. Let's look at another problem, and that's cost. Now, healthcare cost growth is unsustainable everywhere. And as you can see, the UK, Germany, the Netherlands, the US, France, Sweden, healthcare expenditure is far outstripping GDP, income. And policymakers and practitioners are really struggling to cope with this increasing share of their budget being spent on healthcare. Now, I know I'm stating the obvious, but just bear with me. But as you can see, the situation is not unique to any one country. It's happening everywhere, and I'm sure we all know why, things like an aging population and chronic disease, as Oscar explained. Now, we're spending more money, and then the question is, what are we getting for this additional money that we're spending? Are we getting better outcomes? You've just seen that we're not. And so we wonder, we've got significant outcomes variation globally. We've got poor outcomes in a lot of places. We've got increasing costs. That's a problem for humankind, not just for this industry. And so there's something we need to do about it, of course. And this is what shifted my interest from being a practitioner to doing this health systems work that I do now. Now, where Brazil is concerned, let me just go through a few examples. So obviously, a few of these were highlighted by Oscar earlier on, but there's little focus on long-term healthcare programs, widespread. And what that means is that we're going to struggle to meet the care demands of chronic disease, which are now, that's the kind of main problem that the healthcare systems are facing, is to manage patients over their lifetimes. People don't die anymore, which is great, but they have to live with morbidity. They've got to live with a disease that isn't cared for in the right way over a long period of time. The fee-for-service approach is the norm, and this historically has been the norm in the US, but also in other parts of the world as well, like Brazil. And the problem with that is that it encourages volume-driven services, which again, I'll explain in a bit more detail in a moment, but that's a bad thing. The cost containment measures that are used are often poor. Again, this is everywhere. And what that means is that the resources that are used are fewer. They can be lower cost and cheaper, but also, as a result, lower quality, which doesn't focus on outcomes. There's a lack of data on both outcomes and cost. And that means there's a lack of data to drive policy. How do you make decisions if there's no data to help you make those decisions? Or if there isn't the right kind of information or outcomes data to make those decisions, which is really what you need. And then where health information is concerned more generally, there's poor access to that for all stakeholders, including, most importantly, patients. And that means there's a lack of transparency, and there's poor relationships between different stakeholders, providers, payers, etc. Again, this is not just in Brazil, this is everywhere in the world. And finally, the final point, which relates back to the first one, is that there's a disconnect between services across a care cycle. So if a patient has a condition, they need to be treated by different specialties over a period of time. There's a disconnect between those, inpatient, outpatient, emergency care, etc. That leads to redundancy. It leads to a waste, which leads to higher costs, and also a lack of care continuity, which leads to poorer outcomes for the patient. So this is a global problem, but I just want to highlight that it's a problem here as well, just like it is in the UK, the US, and in other places. So the focus, I'm going to jump straight to what we think the solution is, and then I'll explain the background to this, is to shift the focus to value. Now, if we start on the left-hand side, you can see where payers and providers are concerned. This is what's happening in a lot of the world at the moment, in that payers are reducing reimbursement by cutting unit costs. And as I said just earlier, the issue with that is that you start to lower quality, you start to spread your resources more thinly. And providers are trying to maintain an overall profit by seeing more patients, doing more interventions, having more appointments, shorter time. Again, resources being spread far more thinly. And that volume-driven approach is dangerous because ultimately everyone is always very close to the bone, quality is reducing, outcomes are not improving, and costs are still going up because of this chronic disease boom. So if we look at the right-hand side, we can see that actually if payers were to reduce reimbursement by paying for the results achieved, so the data's there, the outcomes are there, and you know what is delivering good outcomes, you pay for that. And you don't pay for things that aren't producing good outcomes. And where providers maintain a profit by innovating to deliver better results at lower cost. So they focus on the parts of their service delivery that produces the outcomes that matter most to patients. What does improve their function? What improves their symptoms? What doesn't? How do we separate these two? And therefore, what should we focus on when we invest? This is what the concept of value in healthcare is to us. And I know there are lots of different versions of the definition of value in healthcare, but we see it as this on the left-hand side. Value is patient health outcomes achieved over the cost of delivering those outcomes. So achieving the best possible outcomes at the lowest possible cost. And that will impact every stakeholder. So if you're a patient, you'll choose your hospital based on its expected outcomes and their share of the cost. Naturally, as a patient, or if you have a relative who has a condition that needs to be treated, and I know I've been in that position recently, you want to know what are the outcomes that my person, my relative, is going to achieve if they go to this hospital for this procedure or for that. And that data does not exist, but if you focus on this, it will. Providers can differentiate into areas where they deliver superior outcomes at competitive prices. And so it provides a ground for competition, healthy competition, obviously, within a private system, which is in most places as well. Payers will negotiate their contracts based on results and encourage innovation to achieve those results. Now, there are some good examples at the end about the role payers can play in this to help to encourage that. And then suppliers will market their products on value, on outcomes. And that shows improved outcomes relative to the cost required to produce those outcomes. So again, the benefit to patients, number one, and then everyone else is clear to see if the focus is on outcomes and cost value. But if you're a patient and you're thinking, how is value defined? I mean, they're not going to understand, the nuances of health systems innovation and reform and whatnot. They just want to know, like I said earlier, where should I go for treatment for X? If it's prostate cancer, then prostate cancer. And at the moment, in the US, this is a very good example, but it happens everywhere. Rankings and outcomes are based on reputation. They're based on metrics that include things like survival rates and mortality. They look at things like length of stay, volume, staffing, etc., rather than true outcomes, the outcomes that you will want to know about as a patient or as a relative of a patient. So for this, if you look at prostate cancer, you're talking about incontinence, you're talking about bowel function, you're talking about erectile function, cancer recurrence. These are the outcomes that you want to base your choice on. And at the moment, patients don't really have that. So we believe the starting point for value-based healthcare reform is to measure meaningful outcomes. So what are the outcomes that matter most to patients? How can we achieve them? The reason for that is, well, there are 5. First of all, outcomes define the goal of the organization and its accountability to patients. So again, whether you are a provider, a clinician, a manager, a payer, if your goal is to achieve good data on these outcomes, then it's clear, no matter who you are, this is the focus. Outcomes inform the composition of integrated care teams. So again, where you're looking at the care of a patient over a care cycle, what you need is to be able to have the right specialties in that group, to be able to focus on outcomes and on the same outcomes, so that one specialty is not thinking about one thing, and then the next specialty is having to clear up some of the mess made here and then focus on different outcomes. The outcomes should be the same whether you are a surgeon, a cardiologist, a nurse, a physiotherapist, etc. It's holistic outcomes that you're aiming for and the interplay between them that your specialty will pertain to. Outcomes motivate clinicians to collaborate and improve together. And I know this because as a background, I know that this motivated me. Physicians, clinicians, nurses, etc., we all want to do well. We all want our patients to have good outcomes. And when the data is there, plain to see, it's hard data in front of you, it's very easy to bring clinicians together to say, let's discuss the data, it's clearly there, how can we learn from each other? It's a very, very fair way to get people to collaborate. Where cost reduction is concerned, outcomes highlight where value can be enhanced. So again, where services that deliver good outcomes and high value exist, where the focus should go, and in comparison, where poor outcomes are produced by other services, where focus should be shifted away from. Without the data, it's very hard to know what those are. And finally, that outcomes enable payment to shift from volume to results. And as said earlier, focusing on volume alone doesn't provide that opportunity to really streamline a healthcare system to deliver good outcomes for patients at low cost. So if we look at the value equation, again, outcomes over cost, and outcomes are the powerful lever to unlock value-based healthcare in a healthcare system. You've got to start with outcomes, because if you measure and improve the health results that matter most for a patient, you can then streamline care delivery to those services that improve those outcomes only. That allows you to reduce costs. And therefore, you increase value in the system. You get better outcomes at equal or lower cost. Now, there are healthcare systems all over the world, and I know I keep repeating this, that see the need to do this. And the OECD, for example, they met just last year, actually, and they're putting together a consortium, I think January 2017, to now work out what are the actionable next steps to drive the healthcare system towards value, in saying that we know very little about whether, where, and how healthcare services achieve the outcomes that patients are looking for. We want health ministers today and in the future to do something about this. So it's on the table. It's on the cards. Everyone is looking to do this. And the question is how? And my job, obviously, is to try and explain to you how we see this journey going. So let's come back to outcomes. And I just want to use a hard example now just to end this particular part of the presentation. So if you look at outcomes for prostate cancer care, and you look at mortality alone, so you've got the national averages there, Germany, Sweden, 5-year survival, and then the average for a highly specialized clinic in Germany called the Martini Clinic, which some of you may have heard of. There isn't much of a difference there. So that's what most healthcare systems measure. It's very difficult to do something with that information, I think it's fair to say. But if you start to measure outcomes like incontinence, erectile dysfunction, outcomes that matter most to patients, you start to reveal quite a lot. German average, Swedish average, Martini Clinic. And you can see, just by measuring, you get a lot of information for how to design your healthcare system, for where to direct policy, for where to invest your money. And if we take this back a step and think, what does the lack of outcome measurement mean beyond that example? So what you have is there's a lack of outcomes data beyond these basic mortality measures and other things like that, which basically means there's a lack of information for patients and providers on whether what we do works. How do you do quality improvement without the right information? Where the information is available, outcomes are hard to compare and they're not standardized because everyone measures different things. So whether they're different clinics, different hospitals, different regions, different countries, the problem is that people measure different things and therefore it's very hard to compare and therefore learn from each other. Outcomes are not often patient-focused, and again, no matter who you are in the healthcare system, if you don't use the patient lens, then you're not defining success from the right perspective. And I mean, if you take a business line kind of look at this, it's the customer perspective in a way. Obviously, I come from a nationalized healthcare system where we don't see healthcare as a business, but it's the same, it's exactly the same concept, where you have to define it from your customer or your patient. And there's a large focus on process measures, which, whilst are useful in trying to drive policy, there's an assumption there that if you change a process, you're going to improve outcomes for patients, which, as we all know, doesn't always work and also leads to gaming of the system as well, which is a problem. So that's just kind of an introduction to value-based healthcare very, very quickly. And as explained, we see there being a certain journey to getting healthcare systems to move in this direction. And that's where I think explaining what ICHOM's role is will help to explain that journey a little bit better. So I think it might be better to take questions at the end, Wilson. So I will keep going, and then we can have a bit of a Q&A at the end. So, ICHOM was formed in 2012. It's a terrible name, I know, but people do remember it. And it was formed to drive the industry towards value-based healthcare by focusing on the outcomes part of the equation. So outcomes measurement, how do we define what these outcomes should be? How do we measure them? How do we store the data? So we were co-founded by Harvard Business School, the Boston Consulting Group, and the Karolinska Institute in Sweden as an independent, not-for-profit organization, very idealistic, very ambitious, but a global focus to engage all stakeholders in the healthcare industry to try and answer this question and move things in this direction. And that's a part of the equation we focus on. Is we believe that we need to define the global standard sets of outcome measures that really matter to patients first, and then by driving the adoption and reporting of these measures worldwide. So you need to work out what are the outcomes that matter most to patients for different conditions, and then you need to measure them. And everyone needs to measure the same thing globally, because if you're doing that globally, then there's no end to how much healthcare systems can learn from each other at any scale, whether it is national registries, it's a clinic, it's rural, it's urban, it doesn't matter. If everyone's measuring the same metrics, they can compare, they can learn. So this is the journey that we see as trying to achieve that mission of shifting the healthcare industry towards value. So starting again with defining the standards, so internationally recognized standard sets of outcomes and related case mix factors, which I will explain in a bit more detail shortly. Once you've defined what you need to measure, you need to actually measure it. And actually, we found a couple of years ago that measuring these outcomes routinely, getting the data infrastructure right, making sure the data quality is high, making sure that data collection is integrated into clinic flows, etc. It's quite a challenge, actually. It's difficult. And so we also help with that, but really different organizations can do that on their own as well. And so the question there really is, how can you adopt and implement these different outcomes routinely in clinical practice? Once you're doing that, then you're away. The next step, once you get the data, you need to know what to do with the data, obviously. And the next step is therefore to benchmark on your outcomes. And so once you have your data, you can risk adjust it, which I'll explain in a bit more detail in a moment. You can analyze it, and then you can organize comparisons on these key outcomes, and you can start to understand a bit better how you're doing. That, we feel, will open the door to collaborating to improve value. So you'll have communities, global communities of healthcare providers and other stakeholders that will work together to go through this journey, which will open the door to establishing outcomes transparency. So obviously, one of the more sensitive issues in healthcare and in other industries as well is no one wants others to know their results, because that could be a threat to their business, and that makes sense. Some of the examples that I'll explain later show how others have managed to get through this, but really taking it in a stepwise approach, starting with anonymized information and data first, actually, is a very, very good way to start. Lauding improvement rather than the best in class, worst in class is also another very good way to do it. So we've seen organizations go through every stage of this journey, actually, and then finally developing value-based payment models where payers and governments will realign financial incentives and promote transparency. Therefore, the winners here are not just every other stakeholder, but primarily patients, who are the key player. And what we see is patients need to be involved at every step of this process. So when you define the standards, patients need to be involved in that. When you measure outcomes, patients will be involved in that. When you benchmark on outcomes, patients will need to be involved in that, etc. I'll explain that in a bit more detail as well. So just very, very quickly, this is how we're funded. We receive various sponsorships and donations from lots of different stakeholders internationally. You have providers, you have payers, professional medical societies, governments, charities, etc. So the message here is really that there isn't a single part of the healthcare system that this won't touch. And internationally, this is being seen now as an area of importance. So how do we do this? Let's go into standard set development. So we bring together these international working groups of experts, so clinicians, researchers, leaders of registries, patient representatives as well, to work together for a period of about 6 to 8 months, 8 to 10 months at times, for about an hour and a half a month, one teleconference, to work out what are the outcomes that matter most to patients. So as part of this, we do a literature review, we run patient focus groups, etc. But then we work out what is the minimum outcome set required for this condition, and then what is going to be pragmatic, what will cover the holistic outcomes that will touch every specialty involved in the care of this patient, and that can be measured, so it's not too burdensome. And we worked with hundreds of individuals as volunteers actually to do this. And when we make these standard sets of outcomes, so this is important because it helps to frame what outcome sets should look like, what they should include, in order to make them globally transferable. So the outcomes are defined around the medical condition, not the specialty or the procedure. The reason for that is obvious in that a specific condition will be treated by multiple specialties and will involve multiple procedures. So where you're defining the outcomes, it should be the product of all of those, not just one at a time. The standard set is a minimum outcome set, so it's focused on the outcomes that matter most to patients. Healthcare systems can and do measure additional things to this as well. So there will be process metrics, there'll be other measures that a specific system will see as important to them. But as a minimum set, if that exists, then everyone will be measuring at least this, which means everyone is measuring the same thing, plus other things of interest to them. Patients, as I said, are directly involved in defining the set. And patient-reported outcomes are really the backbone of each of these outcome sets. So they form the bulk of these outcome metrics, which is important because when you look at things like symptoms, functional status, health-related quality of life, again, we're capturing mortality, we're capturing length of stay. We're not capturing these things. And with the metrics we have, we're struggling. If we have these, maybe we won't struggle as much. A minimum outcome set of initial conditions and risk factors is included to facilitate meaningful comparison, which basically means that if you have 2 units, so you've got 2 hospitals or 2 healthcare systems, one unit or system cares for more complicated patients than the other. One of the challenges you'll find is that they won't compare with each other because one will say, my patients are more complicated, so the comparison isn't fair. So what you have to do is you've got to measure additional metrics, risk factors or case mix variables that will allow you to adjust for those things that make the patients more complicated. As a result, you can then build the statistical models for that, and you can compare fairly. And then the time points and sources of data collection are clearly defined to ensure comparability of results. So people are collecting at the same time points, same sources of data, in the same formats. So this is an example, high level, of the heart failure standard set, which is pretty much complete. So if we start let's start at the 11 o'clock point. So mortality and survival, again, you still need to measure this. It's still an important outcome. But then when you start to move across to things like function and disease control, symptom control, so shortness of breath, fatigue and tiredness, disturbed sleep, activities of daily living, so maximum exertion, health-related quality of life, independence and self-care. Can a patient care for themselves at home if they don't have a carer? Psychosocial health, depression, anxiety, confidence, self-esteem. Complications of treatment, such as reintervention. Treatment side effects. Hospital visits. The number, the frequency. If you can measure all of that, which is possible, as a minimum set, then you're capturing quite a lot, actually. And there's a lot you can do with the data. The scope of this condition that we did is for chronic and acute heart failure, and the treatment approaches that are covered by this will include most. So you've got drugs, you've got invasive therapies, and you have rehabilitation as well. This is just a high-level example of what a standard set looks like. Now, behind each of these domains, these segments, you'll have specific outcomes that you're going to measure. And each of those outcomes is going to be measured by a tool. It can be a patient-reported outcome tool, so a PRO tool, as they're called, or a PROM tool, which are validated for this patient population and which in studies show that actually you're capturing the outcomes that you're trying to capture. And then, once the set is complete, we have a flyer, we have a reference guide, and we have an academic publication. The flyer is a promotional tool, just so everyone can see what the set is. The reference guide contains all the details you would need to actually be able to implement that outcome set. So the outcomes, the case mix variables, the time points, the data definitions, etc. And then the publication obviously announces the release of the set to the medical community. These are the conditions that we've done so far. You can see quite a good spread there. We've obviously got chronic diseases, we've got cardiovascular diseases, we've got mental health, ophthalmology, elderly care. We've got pediatrics as well coming in now. And what we tend to look at is we look at burden of disease, yes. We look at significant outcomes differences and variation as well. And so you can also start to think with different conditions, there's a value burden as well. Significant outcomes variation, high cost, maybe not actually that widespread, but a very high value burden. And as I'm sure you all know, there's a global demand now to measure and compare outcomes. And there are institutions and there are registries all around the world that are measuring or implementing these sets. Now, the reason to say this is that healthcare systems are seeing the value in measuring globally standardized outcome sets. And obviously, you have Brazil marked on the map there as well, where there are sets for stroke, lung cancer, and low back pain that are being measured here. Now, this is where we hope to go next. So in explaining all of that, what I've just said, it sets the ground for this, in that once you have the data, you can pull the data from various different providers, you can put that together, you can risk adjust it, you can analyze it, and you can organize comparisons on key outcomes with a particular focus on patient-reported outcomes, and then you can report back to providers. If you want to identify best-in-class, you can do that. If we look at the right-hand side, so for example, for hip and knee osteoarthritis, if the case mix average complexity is 1, and the case mix complexity of your unit is 0.6, so you basically deal with less complicated patients. If you build that model based on the standard set, you can then organize comparisons across the set. So you can compare yourself to other organizations anonymously, if needs be, and often that's how this starts off. You can compare yourself to the world average. And you can start to understand how you are actually doing when it comes to mortality and readmissions, fine, but also pain, functioning, work status. These are economic problems, quality of life, need for surgery. And that's what the goal is, and that's where we're looking to go next, this year. And this gives you an example from the US. So it was 13 spine clinics across 11 different states in the US using what's called the Ossuary Disability Index, which is a PRO tool. So it's a patient-reported outcome tool. And a lower score, so minus 35 is a better score, minus 15 is a worse score. And if you plot those for these various different units, which they did in this particular study, they found what the variation was, what was the difference in those scores. And what you want to do is study the best performer there. As you can see, you don't know who these are, but you can just see who the best performer is. So if you study that clinic and everyone learns from them, this is what we expect to happen, and this is what has been happening on the right-hand side, in that variation narrows, performance improves. And that's what the potential is here. So I'll just touch on what ICHOM are doing with the life sciences space at the moment before, I think, probably taking a break and then coming back to speak about some successful applications of this around the world. So the IMI, the Innovative Medicines Initiative, we have, we're part of a consortium of 16 organizations that is going to submit a grant for the cardiovascular diseases program. MedTech Europe, we're working closely with them to catalyze procurement for value-based care. And specifically, we're working on a pilot for that in the UK at the moment. And then finally, the pilot projects we're running with the life sciences sector, we've got MEdtronic, obviously, we've got Boston Scientific, Amgen, and Novartis, so medtech and pharma. And the pilots really are looking at supporting the implementation phase and supporting the benchmarking part as well. So the engagement is very much a supportive one to try and catalyze this, to say, let's get to the data so we can do something with it. And that's what we're doing at the moment. Where MEdtronic are concerned, who are one of the front runners in this internationally with their thinking, is this is what we're doing with MEdtronic, or will be doing. So obviously we've got a few things that we've done at the top in dark green and a few things that we're working on at the bottom. So with the Harvard Business Review, we worked on a webinar series that was sponsored by MEdtronic. And what ICHOM did there was we worked on a specific episode of that where measuring outcomes is a key to value-based healthcare. So a lot of what I've said today really in saying that to achieve value, you have to start by measuring, well, defining and then measuring the outcomes that matter most to patients. The Economist as well, we've worked in collaboration with MEdtronic, where we spoke about the projection of how to initiate value-based healthcare through this again, through outcomes measurement as an advisory panel in New York. Our ICHOM conference in May will have the CEO of MEdtronic speaking as a keynote speaker. And what he will talk about is the role of the life sciences space in driving the value agenda, which is obviously what we're trying to do with the pilots at the moment this year. And then the presentations, obviously I'm here today, which is obviously great. And then we presented in New York, as I've said. We've got Gothenburg and also Amsterdam. Where future projects are concerned, we are looking to develop an outcome set for diabetes, which is of interest to a lot of different stakeholders. And what we have is, we have a fund called the Innovation Fund, where MEdtronic provides a sponsorship to that, which is generic across our work. And then, as a priority, we develop the set that is of interest to MEdtronic. Now, the reason we separate the two is because there's obviously this potential that it can be perceived that a life sciences company is having an impact on the metrics that we recommend as a neutral body. And so what we do, therefore, is standard set development is completely separate, but we do get support from life sciences companies for the next two phases, the implementation and the benchmarking phases, to facilitate those. We're looking at a project in Chile at the moment, and a community of implementers for heart disease, specifically coronary artery disease. And there's a community there of 10 cath labs across 9 hospitals that are looking to measure that set. And what that will do for that community is it will seed that particular approach, and therefore, once they measure together, they'll want to benchmark together. The relationships have been seeded, there's trust there, they'll want to compare, they'll want to learn from each other. And finally, an implementation project for another outcome set that we produced for colorectal cancer at a hospital in France, where again, the goal is to get that hospital up and running to measure not just this standard set, but any future standard set as well, without any external help. So the goal really there is to say hospitals are able to do this on their own, but we have to start somewhere. And then finally, the ICHOM conference, which you're all invited to, of course, will take place next month in London. There is a 12-hour flight that will get you there directly from Sao Paulo, I know. So that will take place at the University College London in mid-May, and the focus will be about implementation and impact. So how do you measure these outcome sets, and what are the results that we've seen from the world of outcomes measurement and value-based healthcare? And the registrants we have for that are diverse. As you can see, there are a lot of providers there. There's a lot of life sciences interest as well, academia, government, we've got payers there. So there are a lot of different players that we will have there. We want more from Brazil because they're not on the list for geographically diverse. So if there is interest, please do let me know afterwards. So I suggest we take a break there. And after the break, I'll speak a little bit more about the application of these principles. Should I go? Straight through? Okay. Okay, so the successful application of this theory. And there are lots of examples from around the world. I've picked 5 to go through today. And what we're going to start with is what the challenge is. So what are the key strategic questions that healthcare systems are trying to answer? So how should I measure success? Process compliance and charges, move to outcomes and cost per patient. How should I organize my lines of service? There are specialty departments, shift to integrated practice units where multiple specialties are trying to aim for the same outcomes together. How should I be reimbursed? Fees for service, move towards fee for performance. Start understanding the outcomes and paying for good outcomes. How should I grow and expand? There's a lot of fragmentation in healthcare systems internationally, and really what we want is the integration of care offerings across facilities, because that's better for the patient, it's better for the healthcare system. And what market shall I serve? So at the moment, local is captured, shared across the service lines, but really what you want to do is focus on your good service lines across a geography. Serve a greater region, but focus on what you're good at doing. And then how will technology help? So we go from documenting, which leads to very little. We have a lot of data. It is messy. It's not very useful, to actually optimizing the data for use to improve care. You've seen this. I won't go through it again. I put it up because I thought there'd be a break. But as you can see, these are the 5 things that we're going to highlight in these examples. Now, Stanford Healthcare. I went over there about 1.5 years ago to understand what they're doing. Now, they are routinely collecting patient-reported outcome measures in their neurosurgery clinics. It's an academic hospital. It's a big hospital. Their spine clinic is a bit smaller, obviously. But let me show you what they are doing at the moment.
At Stanford, as an academic medical center, we want to create the leading edge, but that's not enough for patients. We want to take that leading edge and we want to deliver it in a highly coordinated way. So in our neuroscience spine center, when we started looking at how are we delivering care to patients, we said, let's take a full solution-oriented approach to how we measure and assess our performance on quality.
We capture in electronic health records a tremendous amount of data. One thing that has been a weakness is capturing information about our outcomes.
Here at Stanford Healthcare, when delivering outstanding care to patients, we try to look at each step of the process. And as we map out the process, or in the value stream, we started thinking, where can we engage the patient to collect patient-recorded outcome measures so we can figure out how they're progressing and how the outcomes we're delivering are advancing.
We built those tools with our technology partners. We worked with Epic to make sure that they were easy to read and easy to complete by our patients. We tested it in the clinic, and we found it to be very effective.
So this hasn't been done before because people believe that the challenges of building this into an EHR system are insurmountable, that it just simply cannot be done. Patients, when we first present this, are surprised that we're not doing it already. This is a more formal, a more rigorous, more thorough way of capturing these metrics on individual patients as they proceed through their process of care. So when the patient first checks in at the front desk, a prompt will come up that will show if a quality of life questionnaire is needed and whether or not it's been filled out. So if a patient hasn't completed their questionnaire, then as part of their rooming process, the medical assistant will log in to our electronic health record and then pull up the questionnaire into a secure environment where then the patient can answer the questionnaires It goes right into the patient's medical record. As soon as a clinician, when you come in to see the patient, you have that information immediately available. This benefits the patient by engaging them prior to the consultation. They're already thinking about the outcomes that matter to them, and this cue is being provided at exactly the right time.
I like that when the doctor walks into the room, he's already familiar with my condition. It makes me feel more connected to my health care.
As a clinician, the data captured does not impact my practice in terms of the fact that it's no increased time, but it does help my practice in the form of having that information that the patient has supplied.
This should be natural for any clinician to embrace.
Being able to demonstrate that what we do makes a difference to patients every day, and using our electronic medical record and our tools in a really systematic and streamlined process was of significant opportunity and will allow us clinically to be able to demonstrate what we do at Stanford is better.
This approach is only going to rise in importance. Stanford has embraced this vision of demonstrating the value of the care that we provide through capturing these quality of life metrics. And if it only stays in the neurosurgical spine division at Stanford, then it's a colossal failure. We've got to take what we have and really scale it.
That you don't have to be a Stanford to do this, but if you look at what Stanford are doing, it's routine, it's in their care processes, and it is a core part of their business now, is to measure these outcomes. And actually, there's a case study that we've written on Stanford that shows how clinic waiting times have gone down, clinic appointment times have gone down.
This approach
Outcomes have improved. So they're a very good example of this. Now, if you look at Mass General Hospital, again in the States, they've embedded outcomes measurement into care pathways for coronary artery disease. So when a patient requires an intervention and they see a physician, what you make sure of is that you have a PROM survey, you collect patient-reported outcomes, the outcomes that matter most to those patients. You assess the appropriateness for the intervention. So you're not using a volume-driven approach. You're really thinking, before you've done what you're going to do, is the procedure necessary? This obviously involves a lot of shared decision-making. You work out the need for the procedure. You take informed consent, personalized risk consent. You schedule the OR. You do pre-procedure testing. You have the procedure. And then you track the outcomes long-term, because it's going to tell you a lot about whether or not that intervention was appropriate. And it feeds back to what you did at the start. So the data that you have is very, very important. And these are some results that show that. Now note there's a value over volume approach here. And what you have is a reduction in inappropriate interventions. So if you look at the left-hand side, you look at this hospital, Mass General Hospital, MGH. The level of appropriate interventions is very high. Very, very few, maybe or rarely, appropriate interventions take place because of the process that I've just showed you. And if you compare that to the national average, actually, it's very, very good. So the national average, in that they do not do this routinely. And you can see what the result of that is. So if you have fewer inappropriate interventions, you have fewer interventions in total, fewer complications, fewer re-interventions, better outcomes and lower costs, so higher value. And you need the data to do that. You need patient-centered outcomes data to do that. The Martini Clinic I've mentioned already, but the results that they achieve are based on a few things. So first of all, they collect this data, patient-reported outcomes, as well as administrative and clinical outcomes. They identify the top performers, so who are achieving the best results in this at their clinic. So they report back on that regularly. I think it's pretty much every week. They identify any differences or variation in these outcomes across their surgeons and identify opportunities for improvement. They then pair lower performing surgeons with more experienced ones to foster improvement and test these new techniques. So there's an in-house learning there where you learn from the best in class. You test these best practices. you work out, you discover new techniques, new interventions, because you have the data that tells you whether if you cut there instead of there, that led to a better outcome. And rather than doing a study, which will take 5 to 10 years, this is translational medicine. It tells you something very quickly, within a week. Once that's confirmed, the best practices are quickly spread across the organization, and then you keep going. You measure outcomes, you improve. And therefore, what you can start doing is this, which I showed you earlier. You can start to improve your outcomes. So that was the clinic that I showed you earlier compared to Germany and Sweden. So you can see here, on the left-hand side, fine, 5-year survival is good. But these other outcomes, because they measure these outcomes and they go through this continuous quality improvement process that I've just described, they can achieve good outcomes in these areas. And the results are there to see. Now, in Michigan, this is a slightly different type of story where payers and providers came together around the common goal of improving outcomes and lowering costs. Now, the SVP of the payer, there's a single payer in Michigan that covers about 80% of that population. And their goal as a payer, a single payer that was dominant in their particular market, was we need to find a way for the payer and providers to form a trusting, collaborative bond and relationship, use their respective strengths to drive care improvement, and rely mostly on the professional driver providers to do the best possible for their patients. No one could do it alone. So how could they work together to improve outcomes and reduce costs? Now, if you start on the left-hand side, so the payer funded what were called collaborative quality initiatives, CQIs, which were led by providers, and there was a focus to improve outcomes. Now, what happens there is the payer funds the data collection and analysis per condition. The coordinating center, which is the university in this case, it could be another neutral body, evaluates the data and provides reports and results back. The providers obviously measure the outcomes, they measure for their patients. And then there are meetings every now and again to discuss the results. So this is led by the providers, these are led by the clinicians to discuss improvement opportunities. And I've been to a few of these meetings actually, and it's fantastic in that, as I said at the start of the presentation, they focus on improvement. They don't look at the best in class because they know that that creates sensitivities. So you have to be tactful about this, which they were. So it's all anonymized, but you just focus on who's improved the most and how did they get there. And you have patient representatives at every meeting to make sure that there's one voice in the room that aligns all the different stakeholders. So if you look on the right-hand side, you've got an improvement in both outcomes and a dramatic reduction in costs, $600 million in 4 years. Now, if you look at the top, you can see actual versus avoided events. And here you're looking at bariatric surgery. VTEs, so venous thromboembolism, lots avoided, 93%. You would have had that many more had you not taken this approach. Post-surgical death rates, readmissions, length of stay over 5 days. And where savings are concerned, you've got the bottom left PCI or percutaneous intervention for coronary artery disease. So you've got statewide savings, and you've got the savings for Blue Cross, which is that payer that's funded this whole thing. And so there was no exclusivity here in that it covered patients that were part of other health plans as well, which worked. It gave the whole state a lot of savings, not just Blue Cross. And actually, if you look at the bottom, you can see that, so PCI started in 1997, and the others started later. So you can imagine this wave to continue. Now the model, in a bit more detail, what they do there again is you've got the payer, they fund data collection and the coordinating center infrastructure. So there are administrators there are clinical leads in quality improvement, there are researchers there. They provide that oversight. They analyze the data, they share and report the data back. Population level, so there's no means for identification there. And then providers obviously routinely collect and abstract the patient data and submit to the registry via typically it's a web portal actually. And they participate in these meetings, they lead these meetings actually. And then you've got the coordinating center, which provides that clinical leadership. They perform the risk adjustment. They perform the analysis to compare. They share the performance with providers. They report that back. It's de-identified, and they convene the meetings as well. So it's a neutral ground because it's university in this case, but it can be a different neutral body that provides a ground where payers are in the room as well, but providers lead the meetings. And an example here of what they've improved, so obviously you've got these IVC filters which are used during surgery to reduce the chance of having a DVT, causing a PE, obviously, a pulmonary embolism. The problem is they're used too much. And actually, if you use them too much, you get complications. You get movement of this, this device. You get thrombosis. You get fracture of the filter. You get perforation, which goes through the blood vessel. IVC filters are overused, but you wouldn't know that unless you collected the right kind of data. And actually, when they started to do that, they presented the data at one of these meetings, and then they started to reduce their use. And actually, mortality rates went down after this particular type of surgery. And so the principle is you have the outcomes data at the end, and then you work backwards from that data. So you then start to look at what are the processes, what are the care pathways leading to these outcomes, good or bad, and how can we therefore change the way we deliver care to achieve the best outcomes and avoid the bad outcomes. And you can see that there. So for Michigan hospitals, you can see how quickly that went down for surgical mortality, and non-Michigan hospitals reducing as well, but not to the same degree. And the types of things that you can try when you start to look at this, you have a hospital group there that started to videotape bariatric surgery, where, again, there's an opportunity to peer review. So you have the best-in-class teaching those who are not quite there. And what you had was actually your peers would rate you on your technical skill. And there was a strong correlation between rated skill, so skill ranked as not very good, and a high complication rate. And now site visits are conducted to watch each other operate and to provide videos of superior surgeons to everyone. The advantage of that, obviously, is that you seed a general culture of learning and improvement. This actually isn't badly received. People look at this and they say, you know what, we're all learning and we're all improving, but let's do it together. We need the right kind of data to do this together. We need the processes in place, like videotaping here, for example, in order to do that. So they need evidence to improve. In the Netherlands, the Dutch Institute for Clinical Auditing, and this will be the last example that I use, improvements can be achieved before even you actually change your payment structures. And so DICA, the Dutch Institute for Clinical Auditing, is a neutral organization, a not-for-profit as well, that was initially funded by payers, again. So payers and life science companies have a role to play, potentially, in trying to initiate this. So they were funded there, and then they built and then they maintained these national registries for outcomes data. So they led that process to agree on the indicators. They built these registries, which now every hospital in the country has to collect for. So it wasn't initially mandatory, but because everyone started to do it, it was made mandatory. And because at that stage everyone's doing it, it's easy to do that. It's easy to say you have to do it when you're already doing it. But if you look at the clinicians, they felt this was important. They said, okay, well, these metrics are created by the right kind of stakeholders, so by clinicians, by patients, by researchers. We agree with them. Let's measure these, let's partake in this, let's understand how we're doing. And then after that becomes a national registry. And it helps hospitals receive financial support from payers to measure outcomes at that amount there. What DICA do as a not-for-profit is they provide weekly dashboards to hospitals to identify best practices. And as you can see on the right-hand side, again, you've got improvements in results. The results, the data is there to see. So you've got improvements for colon cancer, mortality rate has gone down, length of stay has gone down. These are superficial, of course. There are other outcomes they measure too, more patient-centered, but they're still important. You look at rectum cancer at the bottom, again, mortality and length of stay have both gone down. Can I ask how many are representing payers in the room? Payer organizations. Okay. So I do have some slides at the end which are targeted specifically to payers, which I can go through very quickly. So there's a 3-year journey to implement purchasing of what we call value in healthcare. And again, it's exactly what I've described. You need to build a community of providers ready to measure and report outcomes. And really, the benefits to the payers there are to say that you're driving membership that focuses on quality and you're seen as an innovator in the healthcare space. After that, you're collecting the outcomes, you're reporting them, you're building trust around the data accuracy, and you're proving the concept. Then you benefit there from early quality and cost improvements, and you steer patients to those providers that provide better outcomes at lower cost. Then you can adapt your payment model and structures to include a part linked to outcomes, and then you can increase it every time. So you can start with payment, which is maybe 5% based on outcomes, and you can increase it after that. That strengthens the relationships, obviously, with high-value providers and encourages those that don't achieve good outcomes to improve what they're doing to achieve better outcomes. And this is also shown here, where the immediate focus is really to start with, as I said at the beginning, which is to have those providers measuring the right outcomes, and that sets the foundation for value-based healthcare. And so when you're doing that, what you need to have is the governance in place. You need to identify who the stakeholders are. How will they be represented? Are patients in the room at every conversation or at most conversations? This is obviously vital. What will the infrastructure be like? And this is a challenge for every healthcare system. Data infrastructure, IT, is the biggest hurdle that I've seen to making this happen. It's a hurdle in the UK, it's a hurdle in the US, it's a hurdle in the Netherlands, Sweden, Brazil, Chile, everywhere that I have tried to help do this. And really, it's to say that you need to start small, you need to work with what you have. If you have an EMR, do you integrate data collection into that EMR? Do you get a plugin? Do you build it within the EMR? Do you collect on paper and pen? And do you put that into Excel? There are lots of hospitals doing that. And then how do you link the data across different data sources? There are databases that are administrative, clinical, patient-reported, different service lines. How do you link those? You need to think about that, of course. And then what will the funding model be? Will participation be tied to reimbursement, or will that come later? And then where analysis and reporting is concerned, who will perform the analysis? Now, in the examples that I went through, it was always a neutral organization. If it's the payer, I don't think the providers will necessarily want to play. If it's the providers, they probably won't have the money to do it unless they're funded. So it's got to be an organization that can perform the analysis. And then what level of transparency should there be at the start, and how should it evolve? In most of the examples, we see that it's beneficial to start with the data being de-identified and anonymized, to build the relationships and the collaborations for quality improvement first. Once they exist, people actually hospitals voluntarily come forward and say, you can show our results, you can put our name next to it, we don't mind. And then it's about driving change. So who will organize the quality improvement activities? And then how will individual clinicians be engaged to drive change? And the key is, providers and clinicians are the ones that are going to be doing this on a small scale and on a large scale on a day-to-day basis. And so typically where we've seen clinicians leading this, we've seen a lot of success. So I'm going to stop there, and I think I'll hand over to Wilson to facilitate the next step. Thank you.